Hello everybody, this is EBP Group 1 and we will be discussing the effect of skin-to-skin care with the father after cesarean birth and its effect on newborn crying and pre-feeding behavior.
In our clinical practice, we found that early skin-to-skin contact between a mother and her infant was the most beneficial form of care. In the nursery, the mother sometimes does not have this opportunity for this contact. Can the infant still have the opportunity for skin-to-skin care with a substitute, such as the infant's father, if the mother is unavailable? And if they can, does skin-to-skin care with the father and the infant have a positive effect on the general comfort of the infant? We found a study that researched just that.
There have been many studies conducted on skin-to-skin with the mother and her healthy infant after vaginal deliveries. Previous reports have shown that skin-to-skin care immediately after delivery is the optimal form of care for full-term healthy infants. Some places do not practice direct skin-to-skin care after birth for various reasons such as medical safety issues.
Even in cases when the mother is awake and using spinal analgesia, we mentioned earlier that early skin-to-skin contact between a mother and her newborn directly after cesarean delivery may be limited. Previous studies were conducted to examine if skin-to-skin contact between the father and infant can be a good substitute. These studies concluded that the paternal substitute was found to be as good as incubator care, according to infant body temperature. So the purpose of the study was to further research the benefits, measured by crying and pre-feeding behavior, of paternal skin-to-skin contact by comparing skin-to-skin and conventional chairside cot care for healthy full-term infants by elective C-section if the mother is not available. The care for whether it was skin-to-skin or conventional was done for the first 2 hours after birth. The study design was a randomized controlled trial, and the sample was started with 33 parents. But before the initial stages began, 4 infant-father pairs dropped out, and 29 father-infant pairs decided on further participation. These pairs were selected for either the skin-to-skin group or the cot group. The participants were selected based on specific criteria, such as the cesarean had to be conducted at the 37th to 41st week of pregnancy using a spinal analgesia with bupivacaine. The cesarean section had to be elective due to breech presentation, contraction of the pelvis, or a previous cesarean birth. And the newborn had to be assessed as healthy at the first checkup directly after birth. Originally, 33 father-infant pairs were selected. 4 were excluded from the study based on various factors, such as religious reasons, language difficulties, or personal issues, and personal beliefs. Of the 29, data was obtained from 15 father-infant pairs who were randomly selected to be the skin-to-skin group, and 14 father-infant pairs that were randomly selected for the cot group. Randomization was performed using opaque envelopes. The infants were either cared for in a conventional way, in a cot with the father present in the room sitting on a chair, or infants were cared for skin-to-skin on the father's chest, as he was seated in the chair. The information given was the same, but the fathers in the cot group were instructed not to pick up the child. Wakefulness and pre-feeding behaviors were measured using the NBAS-based protocol. Infants were scored using this protocol during the first minute of every 15-minute period. The initial scoring of the infant behavior was measured immediately before the microphone was attached, and the tape recording was started of the infant vocalization used to measure crying. Samples of the infants were compared in a univariate analysis to become familiar with the material. The skin-to-skin group was compared to the cot group by tape-recorded crying time and the NBAS-based observation of wakefulness, rooting, and sucking. These 4 factors were used to determine crying and pre-feeding behavior for skin-to-skin contact. The independent variables of the study was whether the infant received skin-to-skin care versus conventional cot care. The infants cared for in a conventional cot had the father present in the same room sitting on a chair beside the cot. The infants cared for in skin-to-skin fashion had the infant on the father's chest as he was comfortably seated in an armchair. The dependent variables of the study was the effect of skin-to-skin versus conventional cot methods on the overall comfort of the baby through three different factors. These three factors were crying and wakefulness, measured by the vocal recordings and the NBAS-based protocol system, intensity of the rooting patterns, which is measured by the NBAS protocol, and intensity of sucking activity, which was also measured by the NBAS protocol. Okay. The results of this study show that skin-to-skin contact group babies cried for 5-minute periods for 221 times. The cot group babies cried for 5-minute periods for 162 times. The analysis of tape recording infants crying demonstrated that the infants in the skin-to-skin group cried less than the infants in the cot group. Mean crying time for the skin-to-skin group was 13.4 seconds, compared with the cot group, which is 33.4 seconds. This is a 20-second difference. The infants in the cots group cried less as time passed, while the crying of the infants in the skin-to-skin group decreased rapidly for the first 15 minutes, after being put skin-to-skin with their fathers. The graph provided demonstrates the results of this part of the study. The results also show that infants cared for by skin-to-skin contact became calm and reached drowsy states within 60 minutes. Infants cared for with cot and without skin-to-skin contact became calm and reached drowsy state within 110 minutes. The skin-to-skin contact group showed a decline in sucking activity after 60 minutes of birth. The cot group showed a decline in sucking activity after 105 minutes of birth. But, as the results show, both of these groups show that their lowest level of rooting activities are at 75 minutes. The skin-to-skin group reached another weak rooting peak at 105 minutes, while the cot group reached a second active rooting peak after 90 minutes. The results of the study regarding pre-feeding behaviors based on wakefulness, rooting movements, and sucking movements are shown on these two graphs. The results of the skin-to-skin group is shown on the left, and the results of the conventional cot group are shown on the right. Rooting activity was higher in the cot group than in the skin-to-skin group, as was the sucking activity and overall wakefulness. But activity overall is lower in the skin-to-skin group compared to the cot group. This lowered intensity may have been from a result of the comfort response of having a skin-to-skin contact with the father. It may also possibly be from fatigue or tiredness through skin-to-skin with the father. But it is shown in the graph that after a while, the skin-to-skin group gained some new strength and started to root again, and reached a second peak after 90 minutes. The wakeful crying and actively sucking rooting infants in the cot group might indicate that this group was less satisfied, because they have not been coddled. The fathers were instructed not to pick up the babies. But overall, skin-to-skin contact seems to facilitate coordination of pre-feeding behaviors. Research shows that the father could facilitate the development of the infant's pre-feeding behavior of the newborn infant's life by comforting them with skin-to-skin contact. Although a father cannot breastfeed, he should be seen as a primary caregiver for the infant during the separation of mother and baby. So how can we apply the study for our practice? In our practice, we can encourage fathers of the newborn to participate in skin-to-skin contact with the baby whenever possible, especially if the mother is unavailable. Personally, I've seen that the father has access to both the newborn in the nursery and the mother. And in the time that the mother cannot care for the newborn, the father has the opportunity to use skin to skin contact. Also, I think this intervention is really beneficial because it includes the father in the plan of care for the newborn. And in the time you can utilize with skin to skin contact, you can do teaching for the father to further take care of the newborn. And the father can then educate the mom when they are discharged from the hospital. Using the Johns Hopkins Nursing Evidence-Based Practice Research Evidence Appraisal tool, we decided that the study was low quality or had major flaws. The name of the article was Skin-to-Skin Care with the Father After Cesarean Birth and Its Effect on the Newborn Crying and Prefeeding Behavior. The author was Kirsten Erlandsen, Anne Delina, Ingegerd Fagerber, and Kai-like Christensen. The journal in which we retrieved the article was Birth, Issues in Perinatal Care. The setting of the study was surgical and maternity ward in Karolinska Institute in Sweden. The sample size was 29. The evidence received from the study addressed our EBP question. This was a report of a single research study. There was manipulation of an independent variable, a control group, and the participants were randomly assigned to the intervention and control groups. The study was a randomized controlled trial. The study findings that helped answer the EBP questions were the fact that the skin-to-skin contact groups had decreased crying times. Skin-to-skin contact seemed to facilitate coordination of the pre-feeding behavior, and optimal care is given with skin-to-skin contact with the father if the infant is away from the mother and the mother is unavailable. For the appraisal of the research studies, the researcher identified what is known and not known about the problem and how the study will address any gaps in knowledge. The purpose of the study was clearly presented. The literature was not current within the last 5 years. The sample size was not sufficient based on study design and rationale. The characteristics of the demographics were not similar in both the control and intervention groups. Multiple settings were not used in this study. All groups were equally treated except for the intervention groups. Data collection methods were described clearly. The instruments were reliable. The instrument validity was discussed. No surveys or questionnaires were used for this study. The results were presented clearly. The narrative was consistent with the table content. Study limitations were identified and addressed. Conclusions were based on results. Overall, the quality of the study was low and had some flaws. There was little evidence and an insufficient sample size. The study mentioned that the validity and reliability are strengthened mostly by the fact that the results are in line with other studies in the field, which shows us that the study by itself is not as valid or reliable as it should be. Okay, so this concludes our presentation for our study of skin-to-skin contact and its benefits in the general comfort of the baby, measured by crying and pre-feeding behaviors. Thank you.